Okay, so welcome everyone to the Usmle Step 1 Reproductive, lecture number 4 by Dr. Haider. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? If you guys can hear my voice, can I get a yes in the chat box? Good, thank you so much. We apologize deeply for being so late in starting the class. The reason being is because I have a family emergency which I need to attend from time to time. My father is visiting over here for some health issues, and I've been making some trips to the hospitals and everything else, so that's taking a little bit of my time. And I apologize for that. And that's the reason why I'm having a little bit of difficulty scheduling the classes in proper timing. Hopefully, once he gets better, which will be soon, our class timings will come back to a normal time. I hope you guys understand, and I deeply apologize. So having said that, are we ready to begin the reproductive system, yes or no? Is everyone ready? Okay, good. So before I begin, can I get the attention of one physician, Dr. Tasneem over here, very quickly? Dr. Tasneem, would you be kind enough to unmute yourself and answer some questions?
Yes, sure.
Yes. Were you able to receive the previous lectures?
Yes, I received them.
Did you understand all the text that we have studied yesterday, from anatomy to physiology and all the high yield Usmle step 1 questions, which I have marked
Yes,
down?
I have understood the questions and got time to study them. Thank you.
Okay, no problem. So if you have any difficulties in understanding, please let me know so that I can repeat myself and make sure that every concept is fully understood.
I had one concern.
Yes.
I got the first day 2022 version where the graph for the pregnancy graph for hormones, there was a change in that graph actually.
There was a change regarding which one? Are you talking about this one?
Yeah.
Yes. Which change are you talking about?
There was a for where there it shows it kind of a straight curve here right now, like estrogen is in the below, but in the new one there is slight changes, like the curve shows after 35 weeks estrogen rises, the progesterone falls, and the prolactin also below the estrogen. That's something like that.
Okay, so would you be kind enough to take a small picture of that and post it in the groups so that maybe I can discuss this after the end of the lecture?
Yeah, sure.
Okay, so that's that. So thank you so much, Dr. Nassim, for sharing that with us. And everyone else, are we ready to begin reproductive pathology? Yes or no? Is everyone ready to begin reproductive pathology? Yes, okay, good. So let's begin over here with reproductive pathology, that is sex chromosomal disorders. Now, sex chromosomal disorders are very important for us to understand because the presentations of these chromosomal disorders can be a little bit confusing, right? But you have nothing to be worried about. We will break it down into easy form so that you can remember all of this information very easily. Okay, so having said that, let's begin with sex chromosomal disorders over here. You have Klinefelter syndrome, Turner syndrome, double Y males, and ovotesticular disorders of sex development. Is everyone ready, guys? Are we ready to begin the lecture? Yes or no? Everyone, are we ready? Dr. Alam, Dr. Nafisa, Dr. Noor Mohammed, Dr. S, Dr. BK, and yes, is everyone ready? Yes or no? Okay, good. So let's begin with the first disorder. Let's begin with the first disorder. The first disorder is a sex chromosomal disorder, which is known as Klinefelter syndrome. What is Klinefelter syndrome? Klinefelter syndromes are basically, these are males who has an extra set of Y chromosomes, and who has an extra set of X chromosomes, my apologies. Males are in general XY, right? And in these males, they have X XY, meaning that they have another extra pair of an X chromosomes. So these males over here, they are known as 47XXY because they have an extra pair of an X chromosomes. So what happens is that these patients, they develop female-like characteristics based on the presence of this extra X chromosome. So what happens is that they have a certain amount of features. As you can see that in this male, we call this male a male of Klinefelter syndrome. That's because, as you can see, that this male, look at the hip length of the male, which is wider, right? Usually, females are the ones with wider hips to facilitate pregnancy and birth. But in males, if we have these kind of habitus, this is known as a unicoid habitus, unicoid, tall stature with a unicoid habitus with delayed epiphyseal closure, which means that over here, do you guys remember yesterday I talked about one hormone that is responsible for early closure of the epiphysis? Can you guys name the hormone that is responsible for early closure of epiphysis? The name of the hormone is testosterone, not estrogen. The name of the hormone is testosterone. Testosterone is responsible for early closure of your epiphyseal plate. So over here in these males, if they have delayed closure of the epiphyseal plates, can we expect that the testosterone level in these males are pretty low? Yes or no? The answer is yes, right? That the testosterone level in these males, they are pretty low. The question is why? The answer is that these males, they have an extra set of X chromosomes. What happens is that this extra set of X chromosomes results in testicular atrophy, right? And as we know that the testicles, they're responsible for the production of your testosterone. And since that these males, they have testicular atrophy and testosterone production is decreased, since testosterone production is decreased, luteinizing hormone production is increased, right? Because LH is directly responsible for inducing the release of testosterone. And if testosterone is not there and LH is very high, can we expect that this LH in turn can convert into estrogen? Yes or no? For example, by the action of aromatase or by something else, this LH will increase the amount of estrogen. So can we expect these males to be prone to estrogenic problems such as gynecomastia? that is that is the development of that is the development and the enlargement of the male breasts, right? And female hair development. They may also present with developmental delay, and presence of inactivated X chromosome is known as a bar body. So in these patients, we can see bar bodies. Let me just show you over here very quickly how a bar body looks like. What is a bar body? Can anyone tell me? What is a bar body? Bar bodies are these structures. Okay, these structures. These bar bodies, they are known as inactivated X chromosomes, right? So whenever you see these kind of pictures or bar bodies, for a male, please try to think about the fact that they are trying to describe Klinefelter syndrome. Okay. And the common cause of hypogonadism seen in infertility workup, meaning that this is the most common cause of infertility in men, right? So what will happen is there are multiple questions in your Usmle step 1 exam where they will tell you that there's a male who comes with his wife to the fertility clinic because they have been trying to conceive a child for the last 3 years, but they are failing to conceive a child. And when we do a blood study, we see that there is presence of these sort of bar bodies. What is your most probable diagnosis? The most probable diagnosis is, can anyone tell me the name of the diagnosis is? Klinefelter syndrome. Have I made myself clear? Yes or no? Right? And in these males, since they have gynecomastia, there's a high risk of having breast cancer, increased risk of having breast cancer. So very quickly, in these males, do you think that the seminiferous tubules are producing enough sperms? Last answers, please. This is seminiferous tubules from the spermatogonia, spermatids, spermatocytes, spermatozoon. The answer is no. So if the amount of sperm production is also decreased, at the same time, can we expect, for example, how many of us remembers that the seminiferous tubules have Sertoli cells inside and the Leydig cells outside, right? So over here, we know that the LH will come over here, and they will induce the Leydig cells to secrete testosterone. And the FSH will come, and they will come in contact with the receptors of the FSH in the seminiferous tubules and induce the Sertoli cells to secrete inhibin. Can we expect that the testosterone level and the inhibin level in these patients to be really low? Yes or no? The answer is yes. So if testosterone and inhibin is low, what would happen to FSH and LH in a patient with Klinefelter syndrome? First answer, please. Can we expect them to be high? Yes or no? The answer is yes. So in a patient of Klinefelter syndrome, if you are given a table like this, LH, FSH, testosterone, estrogen, inhibin. Okay, can I get the attention of Dr. Ethar very quickly? If you would be kind enough to unmute yourself.
Yes.
Yes, thank you so much for joining the lecture, and I apologize for signing the lecture so late. Would you be kind enough to tell me what are the changes that happens in LH, FSH, testosterone, estrogen, and inhibin in Klinefelter syndrome?
Okay, LH is going to be high,
Okay, FSH, high.
testosterone low,
Okay,
estrogen is high,
okay,
inhibin is low.
thank you so much. Okay, so that's it. Did everyone understand, yes or no? Okay. So let's move on to the next disease. And the next one that I want to talk about, this is known as 45XO or Turner syndrome. What is Turner syndrome? Turner syndrome is basically a condition where females, they're supposed to have two X chromosomes, XX, but instead they end up having only one X chromosome. That is, instead of having XX, they end up only having X0. Okay, they end up only having X0. So one X chromosome is present, another X chromosome is not here. So as a result, when one X chromosome is there and another X chromosome is not there, will there be a fully functioning reproductive system in the females? Yes or no? The answer is no, right? There will not be a fully functioning reproductive system. So what will happen? These females, they will not have all the female-like features, right? What are the female-like features that I'm talking about? The female-like features that I'm talking about are the fact that females physiologically on a phenotypical basis, meaning phenotype of the females, are such that they promote the normal functions of the females in the life. For example, females are required to give birth, so they should have a wider hip. Females usually do not have, is voice cutting for everyone? Or can everyone hear my voice properly? Yes or no? Fast chances, please. Can everyone hear my voice properly? Yes? Okay. Clear? Okay, good. Okay, so females in general, they are required to have wider hips, they're required to have narrower shoulders, and they are required to have mammary glands to support their live births in the first 6 months so that they can conduct exclusive breastfeeding and everything else. But these females, since they only have one X chromosome and they do not have another X chromosome, what happens is that instead of having wider hips, they have narrower hips and wider shoulders, something that we see exclusively in males, right? And instead of developing mammary glands, they develop what we call as a shield chest. When we say shield chest, what do we mean? For example, in the past, when there were wars, do you remember that when you watch a war film or a film that is based on a war, when they're fighting, they use shields to protect their upper trunk? Yes or no? Fast answers, please. Do you understand what I'm talking about? Yes. So those shields, are they completely flat? Yes or no? Those shields, are they flat or not? The answer is yes. So the same thing is, so the same concept is used for these females who have a shield chest, meaning that they have underdeveloped mammary glands. Along with this, one of the highest yield problems of Turner syndrome is, and I need you guys to remember this, is that these females, they have problems with their ovaries, meaning that there is ovarian dysgenesis, meaning that there is an ovarian abnormality. So if there is an ovarian abnormality, will there be proper production of estrogen? Yes or no? The answer is estrogen production will be decreased. Yes, so estrogen production will be decreased and FSH and LH will be high. And to some extent, can we expect the testosterone level in these females to be higher than normal females too? Yes or no? To some extent, the answer is, since FSH and LH is a little bit high and estrogen is a little bit low, we can expect the testosterone level in these females to be a little bit on the higher side. Now, having said that, there's another thing which I want to talk to you guys about. I want to talk to you guys about the cardiovascular manifestations of Turner syndrome, which is very, very, very high yield for your step 1 exam. Is everyone ready? Yes or no? Is everyone ready? The cardiovascular changes in Turner syndrome. Okay, good. I need you guys to put your utmost attention for this one, because the cardiovascular changes in Turner syndrome are such that females who are suffering from Turner syndrome, they have two things. Number one, they have a bicuspid aortic valve. If they have a bicuspid in aortic valve instead of a tricuspid aortic valve, should they have problems such as aortic regurgitation? Yes or no? The answer is the answer is yes. Okay, so that's the number one issue. But that is not the most commonly tested cardiovascular pathology in your step 1 exam for Turner syndrome. The number one commonly tested pathology for cardiovascular system in Turner syndrome is coarctation of the aorta. Coarctation of the aorta. What is coarctation of the aorta? For example, if this is the heart, right? And from over here, do we have the left ventricle contracting and the aorta forming the arch? Yes or no? Fast answers, please. The answer is yes, right? And then what happens? You have the brachiocephalic trunk, then you have the left common carotid, and then you have the left subclavian. The brachiocephalic trunk then divides to form right subclavian and right common carotid. What is coarctation of aorta? Coarctation of aorta is a condition where there is constriction at the level of, let's say, the aortic isthmus. If there's a constriction at the level of the aortic isthmus, can we expect the blood flow to be higher on the upper part of the body? Yes or no? That is the supply of subclavians and carotids. The answer is yes. And what would happen to the blood supply to the lower parts of the body? Can they be low? Yes or no? The answer is yes. So in these patients, can we expect radiofemoral delay? Yes or no? The answer is yes. Can we also expect asynchronous pulses in the radial artery and the arteries of the leg? The answer is yes. Along with this, the blood pressure, will it be higher in the head neck area and compared to the blood pressure of the lower part of the leg? The answer is yes. Next one. Can we expect these patients to be more prone to develop cerebral aneurysm, cerebral stroke, cerebral hemorrhage? Yes or no? Headaches? The answer is yes. Okay, so that's that. So next time, if there is a female, let's say you guys develop, and let's say that inshallah you guys become medicine physicians, right? And then there's a female patient who you think by the appearance looks like a patient of Turner syndrome, right? If you diagnose a patient as Turner syndrome, are you willing to also do an echocardiogram quickly to sort of exclude the fact that the female has coarctation or not? The answer is yes. Okay, so that's that. So that's very, very important. I want to bring this to your attention. As you can see, the femoral pulse will be less than the brachial pulse. And along with this, these females, they also have a lymphatic defect that results in webbing of the neck. What do you mean by webbing of the neck? This simply means wide neck, that the neck is very wide because of lymphatic enlargement. Not only that, these patients, they also have horseshoe kidney and a high arch palate. And always remember this, Turner syndrome in females is the most common cause of amenorrhea, primary amenorrhea. Okay, so that's that. These patients, can they conceive a child? Yes or no? Fast answers, please. The answer is yes. Okay. These patients, they can conceive a child, but only through in vitro fertilization. Okay. Only through in vitro fertilization. Pregnancy is possible in some cases through in vitro fertilization and hormonal and by hormonal replacement therapies. For example, we can give them estrogen and progesterone and then induce the pregnancy. Now, the thing is, the pregnancy in these females, are they complicated pregnancies? The answer is yes. Why? Because they have streaked ovaries. What does this mean? Does this mean that during pregnancies, these females, their ovaries cannot support the pregnancy by producing the appropriate amount of hormones? Yes or no? The answer is yes. So if we want to maintain the pregnancy in these patients, do we have to supply hormones from outside? The answer is yes. Okay, so that's it. These patients, they have decreased estrogen, increased LH and FSH. Meiosis errors usually occur in paternal gametes. Sperms, they miss the sex chromosome. This is not important. Mitosis errors occurs after zygote formation and loss of sex chromosome in some cells, but not all cells. But so basically what they're trying to tell you is that why do we have Turner syndrome? Why is the X chromosome missing out? Why? The answer is that there could be two errors, one in the level of meiosis, another one in the level of mitosis. Meiosis error usually occurs in paternal gametes, meaning that on the father's side of the gametes, if there is any problem with the division of the cells, and let's say one cell has one X chromosome and another cell has two X chromosomes, then that can result in that paternal gamete fertilizing the ovum, resulting in Turner syndrome. And mitosis error occurs after the zygote formation, loss of sex chromosome in some cells, but not all cells, which is known as a mosaic karyotype. For example, how many of us are aware that there are concepts such as somatic mosaicism, Robertsonian translocation, and different sorts of functional problems for which we end up with chromosomal disorders. For example, how many of us are aware that mosaicism and Robertsonian translocations are the reason why we end up with Down syndrome? Down syndrome, right? Yes, exactly. So over here, I'll talk about what is mosaicism, what is translocation, what is an error. I'll explain them when I'm talking, when I'm taking the lecture of genetics. Okay, but for now, this is not a step one question as of yet. I personally believe this can become a step one question in the future. That is, why do we get Turner syndrome? There are two reasons. Number one is a mitosis error. Number two is a meiosis error. Meiosis error occurs in paternal gametes. Mitosis error occurs after the zygote formation during the replication to form blastocyst. Okay, that's that. Mosaic karyotype, for example, 45X or 46X6 is associated with increased risk for gonadoblastoma. Not important, not important. Okay. So very quickly, can I get the attention of one physician? Let's ask Dr. Alam over here very quickly. Please unmute yourself and tell me the changes that will happen FSH, LH, estrogen in a female of Turner syndrome. Fast answers, please, Dr. Alam. Yes. LH in Turner syndrome, high or low?
Increase like length of time.
High. Okay. FSH, high or low?
High.
High. Estrogen, high or low?
Low.
Low. Very low. Thank you so much. Okay. Okay. Next one. Next one is a double Y male. Okay. Double Y males are not important for your exam. But let's still understand what this is. This is simply, instead of receiving one Y chromosome, they have two Y chromosomes. Okay. The problem is that if they have two Y chromosomes now, do they have more chances of developing male secondary sexual characteristics a bit faster? Yes or no? The answer is yes. Why? Because there's another Y chromosomes, and Y chromosomes are responsible for the SRY gene. SRY gene is directly responsible to SRY genes are directly responsible for the initiation of testosterone production. But these males, everything is okay about these males. They have normal fertility, everything is normal. Maybe testosterone level is a little bit high, and they suffer from severe acne, learning disability, and autism spectrum disorder. Severe acne, learning disability, and autism spectrum disorder. Not high yield, that's that, okay? Another thing I just want to bring to everyone's attention, what, for example, let's say in US, right? Are we studying the medical license exam, USMLEs, to become US physicians? Yes or no? The answer is yes, right? So shouldn't we be tested on diseases that are more common in the US? The answer is yes, right? So the thing is, since always remember this, that USMLE step one will test you on diseases that are more common, that are always more common. Diseases that are not common, diseases that are rare, diseases that are difficult to make a question with, right? For example, let's say that you are responsible for making a USMLE step one question. Is it going to be easy for you to make a question about double Y males? Because when you tell your students in your question that there is a male who comes to you with normal fertility, severe acne, learning disability, and autism spectrum disorders, do you understand that the students will not choose double Y males? They will instantly choose something else, let's say Fragile X syndrome, or they can choose, let's say, exogenous steroid abuse, something that is more common. So do you think that there's a possibility that they will make questions for diseases that are not common at all? The answer is no. Okay, so that's that. So next time, why am I talking about this? I'm talking about this because next time when you read first aid, Should you be or should you not be aware of diseases that are more common or less common? The answer is you should be aware of diseases that are more common. So in that way, can you put more emphasis on learning those diseases better? Yes or no? The answer is yes. Okay. So that's what I'm talking about. So having said that, Klinefelter syndrome is very, very high yield. Turner syndrome is very, very high yield. Double Y males are not important, not that high yield. Next one is ovotesticular disorders of sex development. What is ovotesticular disorder of sex development? This is called true hermaphroditism. Hermaphroditism basically means the presence of both male and female sexual organs or reproductive organs. So over here, these humans, they have both ovaries and they have testicular tissues that are present. And the genitalia is ambiguous, meaning that it's difficult to basically identify what this genitalia is. This could be male, this could be female. So in these patients, for example, let's say that in step 2 CK, if I ask you, there's a female who comes to you who has ambiguous genitalia. She came to you with primary amenorrhea. What are the ways that you can manage this patient? Can anyone tell me what is the way that you can manage this patient? Fast answers, please. The answer that I'm looking for is, can anyone tell me what is the answer I'm looking for? How will I manage a patient of ovotesticular disorders of development? Karyotype, okay, so we do karyotype. And then what else? Then what else do we do? Now, the answer that I'm looking for is multidisciplinary treatment. Multidisciplinary treatment, meaning that do you have to address the patient's psychological point of view? Yes or no? The answer is yes, right? Do you have to address the patient's endocrinological point of view? Yes or no? The answer is yes. Do you have to address the patient's fertility point of view? The answer is yes, right? And can you expect that these patients to have an identity crisis or an identity disorder? The answer is yes, right? That they could be confused about how they should identify themselves as a male or as a female. And that's one thing. Next thing is, can you give them the liberty to choose their own pronouns? Yes or no? For example, nowadays, are you guys aware that people, they choose their identity by having the liberty to be called by a certain pronoun? That is he or him, she or her, they or them. Okay, as simple as that. So you basically give the patient all the liberty and you tell them that the treatment is a multidisciplinary treatment, meaning multidisciplinary approach. Okay, so that's that. Next one. Next one is, let's talk about diagnosing disorders of sex hormones. Okay, so diagnosing disorders of sex hormones, what do we mean? What we mean is this. For example, let's say over here. Okay. Okay. Let's say over here, let's read this portion first. If we have a patient who has a defective androgen receptor, right? If the androgen receptor is defective, what should happen to the testosterone level? Should it be high? Or, I mean, should it be high, yes or no? The answer is yes. Because testosterone is not being able to bind to the androgen receptor, but can it be produced from the testicles and the seminiferous pubis? The answer is yes. And on the other hand, since testosterone cannot bind to the androgen receptor, can it provide a negative feedback to the anterior pituitary? Yes or no? The answer is no. If it cannot provide a negative feedback, what would happen to the LH level? Would it be high or would it be low? It will be high. Very good. Next one. If there's a testosterone secreting tumor, what should be the testosterone level, high or low? It should be high. If it's excessively high and the receptors are functioning properly, what will happen to the LH level? Will it be high or will it be low? It will be low. Very good. Next one is hypergonadotropic hypogonadism. What do we mean by hypergonadotropic? Meaning that, can we expect when they say hypergonadotropic, they mean that there's excessive GnRH secretion? Yes or no? GnRH is high. If GnRH is high, what would happen to the LH? Will it be high or will it be low? LH is also going to be high. But if there's hypogonad, meaning that the gonads are small or there's something wrong with the gonad, what would happen to the testosterone level? Testosterone level is going to be low. Very good. Next one is hypogonadotropic hypogonadism. Can we expect both testosterone and LH to be low? Yes or no? The answer is yes. Okay. So that's that. Is everyone clear? Yes or no? Okay. Next one. Next one is other disorders of sex development. What are some other disorders of sex development? Disagreement between the phenotypic sex. What do we mean by phenotypic sex? That is the sex of a human being described by the appearance of the external genitalia, influenced by the hormonal level and the gonadal sex, meaning that if the female, let's say a human has a penis, but they also have ovaries, right? Can we, if they have ovaries and a penis together, for example, let's say that there is a, will there be a discrepancy between the fact that if it's a male or a female, yes or no? The answer is yes, right? So formerly, this was called hermaphroditism and pseudo-hermaphroditism. Now, this is most commonly referred to as intersex, right? So what are the different types or what are the disorders of sexual development? Let's talk about the first one. This is 46XX disorders. What happens is ovaries are present, but external genitalia are virilized or ambiguous, meaning that ovaries are there, the external genitalia, they appear in the shape of a penis. Due to excessive and inappropriate exposure to steroids during early gestation, this could be due to congenital adrenal hyperplasia, or isn't there a possibility that some mothers can be abusing steroids when they are pregnant? Yes or no? Especially if the mothers are bodybuilders, for example. Let's say that a mother is a professional bodybuilder and she puts her bodybuilding needs above her normal gestation. So if that's the case, isn't there a possibility that the baby can be exposed to excessive amount of testosterone? The answer is yes, right? So if that's the case, can we expect these babies to have unusual, for example, how many of us are aware that the genital tubercle is responsible for giving rise to the glans penis and the glans clitoris? Do you guys remember this? Yes or no? Our discussion with the genie and everything else, right? Okay. So isn't there a possibility that under the influence of testosterone, a normal female can have glans clitoris? Instead of having that, they can have a glans penis because of the high amount of testosterone exposure in the intrauterine gestation. The answer is yes. Okay, so that's that. Next one is 46XYBSD. This is the fact that testes are present, but external genitalia are female or ambiguous, meaning that testes are there, but over here, these females, they have, these patients, they have external genitalia that looks like a female external genitalia, as simple as that, okay? So that's that. Now, having said this, I want to talk about two high-yield diseases. I want to talk about 5-alpha reductase deficiency and androgen insensitivity. Androgen insensitivity syndrome. Is everyone ready? Yes or no? Okay. Now, what is 5-alpha reductase deficiency? 5-alpha reductase deficiency is a disease where testosterone cannot be converted to dihydroxytestosterone. So before puberty, for example, before puberty, can we expect these patients to be female-like? Yes or no? Fast answers, please. The answer is yes. Okay, now let's talk about androgen insensitivity. Androgen insensitivity is a disease where the androgen receptors are not functioning. If the androgen receptors are not functioning, can we expect the testosterone to not work in these people? Yes or no? In these humans? The answer is yes. So can they also phenotypically appear as females, 5-alpha reductase and androgen insensitivity? The answer is yes, right? Now, the question is, both of them, 5-alpha reductase and androgen insensitivity, do they have testes or do they have ovaries? That's answer, please. Do they have testes or ovaries? Very good. They have testes. So if they have testes, will they have normal menstruation? These phenotypically appearing females who are actually males, will they have menstruation? The answer is no. So can we expect these females to come to your clinic with primary amenorrhea? The answer is yes. Okay. Now, what is the difference? The difference is that patients with 5-alpha reductase deficiency during puberty, do we have excessive surge of testosterone during puberty? Yes or no? The answer is yes, right? we have excessive surge of testosterone. So these patients of 5-alpha reductase deficiency, phenotypically in the earlier stages, they can appear as females, but at puberty, they will start developing virilizing characteristics due to excessive surge of testosterone. Because in 5-alpha reductase deficiency, the androgen receptors, they are functioning absolutely normally. So when there's an excessive surge of testosterone, they can bind to the androgen receptors and they can cause virilizations. And also, since testosterone is functioning pretty well, in 5-alpha reductase deficiency, we do not have cryptorchidism. But in androgen insensitivity syndrome, the testosterone receptors are not functioning. The dihydroxytestosterone receptors are also not functioning. So despite if there's a testosterone surge in puberty in androgen insensitivity syndrome, will they have virilization or correction of their phenotypical features? Yes or no? The answer is no. So these patients, will they still appear phenotypically as females? Yes or no? The answer is yes. And these patients, will they have cryptorchidism? Yes or no? The answer is yes. If they are unaware of this cryptorchidism, let's say that their testes stay in the abdomen due to the absence of the dihydroxytestosterone and testosterone working properly on the receptors, can we expect these patients to have testicular carcinomas? Yes or no? The answer is yes. Okay. Now, very quickly. So very quickly, androgen insensitivity and 5-alpha reductase. Over here, the most common clinical feature could be primary amenorrhea. Okay, so that's that. Did you guys understand the difference between 5-alpha reductase and androgen insensitivity syndrome? Yes? Okay, good. Now, next one is disorders characterized by physical features. If there is a patient who has, let's say, uterus, right? Uterus is there, but the mammary glands are not there, right? The uterus is there and the mammary glands are not there. We call this hypergonadotropic hypogonadism, meaning that everything is functioning pretty well, but the ovaries, for example, they're not producing enough estrogen. As a result, these patients, they can have Turner syndrome, genetic mosaicism, or pure gonadal dysgenesis. What is hypogonadotropic hypogonadism? If I say hypogonadotropic, is there something wrong with the ovaries, or is there something wrong with the GnRH production by the hypothalamus? Last answer, please. GnRH production by the hypothalamus, right? So these patients, they can have CNS lesions, for example, tumors that are pressing on the hypothalamus, for example, or any other lesion, or they can have a disease called Kallmann syndrome. Kallmann syndrome is a disease where patients have difficulty with smelling things. They have anosmia, meaning absence of their olfactory bulb. Along with that, they also have hypogonadism. This is something I'll talk about later. Let's move forward. If there's a female who does not have uterus, but they have a breast, right? But they have the mammary glands. If they have a mammary gland and they do not have a uterus, can we expect that there's a possibility these patients are genotypically males? Yes or no? Yeah, and do you guys remember I talked about that? I talked about Mullerian agenesis or Mayer-Rokitansky-Kuster-Hauser syndrome. Yes or no? Do you guys remember Mayer-Rokitansky-Kuster-Hauser? Okay, what is Mayer-Rokitansky-Kuster-Hauser syndrome? This is a disease where we have abnormal development of the paramesonephric duct. Yes or no? The paramesonephric duct is responsible for forming the uterus, proximal vagina, and the upper part of the in the upper portion of the reproductive organ. So if we have Mullerian agenesis or Mayer-Rokitansky-Kuster-Hauser, then can we expect females to have external reproductive organs, but absence of internal reproductive organs? Yes or no? The answer is yes. Okay. Now, if a female, okay, very quickly, I just want to ask a couple of questions to one physician. Let me see if they can answer them. Please write me in the chat box. Fast answers, please. All you have to do is make the diagnosis. Fast answers, please. We do not have a lot of time. Anyone who wants to help me out with some answers very quickly? Fast answers, please write me in the chat box. Anyone who's brave and who is confident that they know the diseases and the physiologies and the pathologies. Okay, if no one is willing to help me out at random, then let me choose someone at random. Can we ask, who do I want to ask? Who has their exam in the next couple of months? Fast answers, please. We do not have a lot of time. Who has their exam in the next couple of months? Guys, Dr. Hagar. Okay, please unmute yourself, Dr. Hagar, and answer me the questions.
Yes, doctor. Hello, everyone.
Okay, thank you so much for helping us out. Okay, a couple of questions for you since you have your exam in a couple of months. Now, first question is, if there is a female who comes to you with primary amenorrhea in your clinic and you do an ultrasonogram and you find that this female has no internal female genital organs, what is your most probable diagnosis?
Um, uh, she does not have what? Sorry, I can't hear.
She does not have female internal organs, internal reproductive organs. She does not have a uterus. She does not have uterus.
5 alpha reductase, I guess.
Nope. Okay, let me ask someone else. Dr. Hagar, thank you so much for helping us out, because I think you have your child in the back, so you need to take care of that. No problem. There's absolutely no issue with child being in the. There's absolutely no problem. No problem at all. Let me just ask someone else. Okay, let's move on to Dr. Ethar very quickly. If you have a female patient, Dr. Ethar, who comes to your clinic and with primary amenorrhea, and you see that this patient has no internal female reproductive organ, no uterus, no ovaries, no proximal vagina and everything. I mean, no uterus and no proximal vagina, but ovaries are there. What is your diagnosis, Dr. Ethar?
The ovaries are there. I think she's androgen insensitivity.
Nope, she's not androgen insensitivity. And she does not even have a uterus. She does not have proximal vaginas and everything else. Isn't there a possibility that if she has complete absence of these organs, these organs did not develop? Yes or no?
Yes.
If they do not develop, what do we call this disease where they do not have any internal reproductive organ? Do we call them Mayer-Rokitansky-Kuster-House?
Yes.
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 Okay. Next clinical scenario. You have another female who comes to your clinic with primary amenorrhea. When you do abdominal palpations, you find bilateral adnexal masses. Next is you find that the genitalia in these females are completely female genitalia, right? And when you do an ultrasonogram, you find that the bilateral adnexal masses are masses in the inguinal canal. Bilateral inguinal canal masses. What is your most probable diagnosis?
The masses most probably are testes.
Yes.
So it might be androgen insensitivity.
Very good. This is androgen insensitivity. Okay. You have another female who comes to your clinic, who has been coming to your clinic for the last 3 years, right? So for the last 3 years, this patient of yours has had primary amenorrhea. Now, all of a sudden, this patient comes to you with virilization. The patient started coming to you at the age of 13. Now, at the age of 16, the patient is having virilizations, growth of the glans clitoris to now is forming into a glans penis. She also has voice deepening. She also has a little bit of shoulder widening. What is your most probable diagnosis for this patient?
5 alpha reductase deficiency.
5 alpha reductase deficiency. Very good. If you have another female who comes to your clinic with primary amenorrhea, the patient has a shielded chest, webbing of the neck, and you see that the ovaries are really small in these patients. What is your most probable diagnosis?
She's Turner.
Turner syndrome. Very good. Okay, thank you so much. Now, do you guys realize how many different types of primary amenorrhea problems you can face, yes or no, in your USMLE step 1? The answer is that there are multiple types of primary amenorrhea problems you can face in your USMLE step 1. So based on this, you have to be very careful what the question is asking you. Okay. Can you elaborate 5 alpha reductase deficiency? Yes, 5 alpha reductase deficiency is a deficiency of an enzyme where testosterones are not converted to their active form, that is dihydroxytestosterone. As a result, what happens is that the male patients, they appear phenotypically as females in the earlier stages, But during puberty, there's a sudden surge of excessive testosterone that causes virilization, and the female patients now start to appear phenotypically as males. This is known as 5-alpha reductase deficiency. Have I made myself clear? Yes or no? Are we clear? Yes or no? Okay, next one. Next one is placental aromatase deficiency. What is placental aromatase deficiency? What is the job of this enzyme aromatase? Are they responsible for converting testosterone to estrogen? Yes or no? The answer is yes, right? So placental aromatase deficiency is the deficiency of an enzyme where there's inability to synthesize estrogen from the androgens, right? So if estrogens are not synthesized from the androgens, we have masculinization of females. So females, they have ambiguous genitalia, high testosterone and androstenedione, and they can present with the virilization of pregnant patients. For example, fetal androgens can cross the placenta. For example, if the placenta does not have aromatase, right? If the placenta does not have aromatase, for example, placental aromatase deficiency, during pregnancy, can we expect for example, if that during pregnancy, let's say a female is carrying a male child, will there be a lot of production of testosterone in the male child? Yes or no? Fast answer, please. The answer is yes. In the from all of the production of testosterone in the male child, isn't there a possibility that a small amount of testosterone can cross the placenta and enter into the maternal circulation? The answer is yes. So in a normal female, what happens is that the placenta has aromatase. So whenever testosterone tries to enter into the maternal circulation, the placental aromatase in a normal female who does not have a deficiency will convert the testosterone to estrogen and prevent virilization in mothers. But if a mother does not have an aromatase in their placenta, can we expect mothers to be early virilized? Yes or no? Have male pattern baldness, deepening of voice deepenings, shoulders, acne, and all of those things? The answer is yes. Okay. So this is known as placental aromatase deficiency. Next one is androgen insensitivity syndrome. We have talked about this. This is a defect in androgen receptor resulting in female appearing genetic males. So there's a female external genitalia with scant pubic hair and rudimentary vagina. And there's complete absence due to presence of anti-Mullerian hormone from the testis, meaning that Mullerian inhibiting factor is being secreted from the testis. So that's that. Since there is production of Mullerian inhibiting factor that is being produced over here, what happens is that we have the development of the female external genitalia, as simple as that. So patients, they develop normal functioning testis. So the testis that is produced is normal. And these patients, they can have increased testosterone and estrogen, but they will appear phenotypically as male or female. The answer is they will appear phenotypically as females. Okay, have I made myself clear? Yes or no? Now, next question. This testosterone that is produced by these androgen insensitivity syndrome patients, will it be able to cause virilization in this patients? Yes or no? This testosterone, can it cause virilization? The answer is absolutely not. Why? Because the receptors are not functioning. So it does not matter how many testosterone or how much testosterone you give to the patient. Since they do not have a functioning androgenic receptor, they will not undergo virilization. Since they do not undergo virilization, their external genitalia appear as a female external genitalia. Okay. Next one is 5-alpha reductase deficiency. This is an autosomal recessive disease where we have genotypically males, but they're unable to convert testosterone to dihydroxytestosterone. As a result, they have ambiguous genitalia. When increased testosterone causes masculinization and increased growth of external genitalia especially during puberty. Okay. So testosterone estrogen levels are normal. LH is normal or increased. Internal genitalia are also normal in these patients. Okay. Now, did we understand androgen insensitivity syndrome and 5-alpha reductase deficiency? Yes or no? Fast answer, please. These are very, very high yield. Okay. Let me explain. If there's a patient who comes to your clinic, okay, if there's a patient who comes to your clinic with female external genitalia, primary amenorrhea, and abdominal masses, and you see that the uterus is absent, the ovaries are absent, the proximal vaginas are absent. What is your diagnosis for this disease? Fast answers, please. Androgen insensitivity syndrome. Very good. Now, the difference between Mullerian agenesis and androgen insensitivity syndrome is, in Mullerian agenesis, will there be presence of ovaries? Yes or no? The answer is yes. In androgen insensitivity syndrome, will there be presence of ovaries? Yes or no? The answer is no. In Mullerian agenesis, do we have cryptorchidism? Yes or no? In androgen insensitivity, do we have cryptorchidism? Yes or no? Okay. In 5-alpha reductase deficiency, do we have virilization at a later stage in life? Yes or no? Very good. In 5-alpha reductase deficiency, do we also have early ambiguous genitalia and later external phenotypically male genitalia? Yes or no? The answer is yes. Okay. So that's it. Next one is, let's talk about Coleman syndrome. What is Coleman syndrome? Coleman syndrome is failure to complete puberty, a form of hypogonadotropic hypogonadism, meaning that the gonadotropin hormone secretion is very low. As a result, these patients, they have Coleman syndrome. Defective migration of neurons and subsequent failure of the olfactory bulbs to develop. As a result, since we have decreased migration of the neuron and decreased formation of the olfactory bulbs, these patients, they suffer from two things. That is, not only do they suffer from hypogonadism, they also suffer from decreased olfaction or anosmia. Have I made myself clear? Yes or no? So if there's a male or a female patient who comes to your clinic with infertility, and they also come to you with smell issues, can we make the diagnosis that this is a diagnosis of Coleman syndrome? Yes or no? The answer is yes. Okay. Okay, good. Now, are we ready to talk about pregnancy complications? Yes or no? Okay, good. Now, let's talk about pregnancy complications. What are some complications that are associated with pregnancy? Very, very easy to understand that we have a certain amount of issues that can go wrong in pregnancy, right? So pregnancy complications, we have abruptio placenta, placenta previa, right? Placenta accreta, increta, percreta. Then what else do we have? We have vasa previa, right? So what are these things? How do they present themselves and how we approach this sort of diagnosis? Okay, so let's begin with the first one. The first one is abruptio placenta. What is abruptio placenta? Abruptio placenta is a clinical condition where abruptly, in an earlier stage, the placenta gets separated from its attachment with the uterus. If the placenta gets separated from the attachment of the uterus, will the child receive adequate amount of oxygen, nutrition? The answer is no. Will the mother have abdominal pain? Yes or no? Fast answers, please. The answer is yes. Obviously, the mother will have abdominal pain because a part of their organ is coming off, right? So that's that. Next one is, will the mother always have bleeding? Yes or no? The answer is there could be bleeding, there could not be bleeding, right? If it's a complete abruptio placenta with a concealed hemorrhage, meaning something like this, right? That the hemorrhage, there is bleeding, but the bleeding is not coming out. The blood is not visible. Then they will have concealed hemorrhage. If it's a partial abruption, meaning one part is attached, as you can see, another part is coming off. In these cases, there will be bleeding, and that bleeding will have a way to come down through the vagina. So in these patients, they will have an unconcealed hemorrhage, as simple as that. Now, what are the clinical features? First and foremost, let's talk about why do we get abruptio placenta? Why? Meaning that whenever we have a USMLE step 1 question, first and foremost, do we have an age of the patient? Fast answers, please. Yes or no? The answer is yes. Do we have the sex of the patient, male or female? Yes or no? Yes. Do we have the clinical features of the patient? Yes or no? Comes to your clinic with this problem? Yes or no? Next, do we have a history of, yes or no, that a female patient of 36 years comes with abdominal pain with a history of, let's say, smoking? Yes. Okay. So whenever they say a history of in the question, are they explaining the presence or absence of risk factors? The answer is yes. Okay. So whenever they say a history of, they are telling you if the risk factors were present in the patient or not. So what are the risk factors? Why do we develop abruptio placenta? Now, the risk factors are that, number one, if a part of the placenta is coming off, could it be due to the fact that the pregnant mother received some sort of a trauma to the abdomen? Yes or no? The answer is yes. So number one risk factor is trauma. Next one is, if we have smoking, do we have the release of nicotine, which is a vasoconstrictor? Yes or no? If it's a potential vasoconstrictor, the answer is yes. If there's vasoconstriction, will the tissues be strongly adherent to the uterus or not strongly adherent to the uterus? The answer is the tissues will not be strongly adherent to the uterus. They will come off due to the vasoconstrictor effect of nicotine. Next one is hypertension. If we have hypertension, excessive amount of blood pressure that is going through, can we expect that high amount of blood pressure to sort of push the placenta out to make sure that it's not attached very well? The answer is yes. Same way, if there's a mother who is abusing cocaine, is cocaine a vasoconstrictor or a vasodilator? The answer is cocaine is a vasoconstrictor. Very good. If there's a mother who's abusing cocaine, then that can also put the mother at risk of having abruptio placenta. For the same reason, if there's vasoconstriction, then the blood vessels will not be attached. The blood supply will not be adequate, and the tissues will become severely lax and loose, and they might come off. And another one is preeclampsia. What is preeclampsia? Preeclampsia is a condition where mothers, they have hypertension with the hyperproteinuria, edema, but they do not have seizures. So in preeclampsia, the question is, do the mothers have hypertension? Yes or no? The answer is yes. If the mothers have hypertension, does that put them at risk of developing abruptio placenta? Yes or no? The answer is yes. Okay. Now, what are the clinical features? If a placenta is coming off, will there be severe bleeding? Yes or no? The answer is, will there be severe pain? My apologies, in the abdomen. The answer is yes, right? Obviously, if a part of the abdomen or if a part of the placenta is coming off, there will be severe pain. Why will there be severe pain? Because when the placenta comes off on a physiological level, there is excessive breakdown of arachidonic acid, resulting in the formation of prostaglandins and bradykinin in excessive amount. Will that produce a lot of pain? The answer is yes. Okay, so that will produce a lot of pain. Next one is, can we also have a little bit of bleeding? Yes or no? If it's a non-concealed partial abruptio placenta, the answer is yes. Okay. Another one is, abruptio placenta, is it more common in the early stages of pregnancy or in the late stages of pregnancy? The answer is abruptio placenta is more common in the late stage of pregnancy, in third trimester. And these patients, can they have fetal distress and intrauterine fetal death? Yes or no? The answer is yes. Another thing is that for example, whenever we have a placental abruption, or whenever we have placental substances that are reaching the maternal circulation. For example, do we have a lot of, for example, let's say if a little bit of the amniotic fluid or if a little bit of the phospholipids of the placenta, if they reach the maternal circulation, can we expect that amniotic fluid and that phospholipid to induce disseminated intravascular coagulation in the mother? Yes or no? Active coagulation? The answer is yes. Okay. So this is mediated by the tissue factor activation. Tissue factors are activated if amnion or phospholipids, they reach the maternal circulation. So that's that. We will have activation of the external and the internal pathway. Okay. So that's that. Now, how will you manage this patient? Do we go for active CS delivery? Yes or no? The answer is yes. Emergent CS delivery. Do we go for emergent CS delivery? Yes. Okay, good. Very good. So that's that. Next one is placenta accreta spectrum. What is placenta accreta spectrum? Placenta accreta spectrum is a spectrum where, isn't there a possibility that when the placenta gets attached to the wall of the uterus, can they get attached very deeply with the uterine wall? Yes or no? The answer is yes. If they get attached very deeply with the uterine wall after pregnancy, can we have problems such as retention of placenta? The answer is yes. And also during the removal of placenta, can we have severe postpartum hemorrhage? Yes or no? The answer is yes. Can we also have uterine rupture, uterine inversion, and all of those things? The answer is yes. So the complications are endless, right? So why do we have a placenta accreta spectrum? For example, during gestation, the uterus, does it prepare its layer so that the fetus can come and implant properly? Yes or no? The answer is yes. What is the name of the endometrium, which gets filled up with blood and nutrients and glands so that the uterus can come? I mean, so that the fetus can come and bind. Not myometrium. This is known as, I talked about this. This is known as decidua. Do you guys remember this? The decidua is the mother's endometrium that is filled up with blood, glands, right? And the decidua is the endometrium that will host the fetus. So during this development of the decidua, when the endometrium gets swollen up, if there is a defect in the decidual formation, when the placenta gets attached to the uterine wall, can they get directly attached to the uterine myometrium? Yes or no? The answer is yes. Okay. So in that case, can we have a placenta accreta or a placenta problem? Yes or no? The answer is yes. Okay. So defective decidual layer will result in abnormal attachment and separation of the. Can you just give me 1 second, please? একটু সাকশন করে দিন তাহলে। হ্যাঁ, সাকশন মেশিনটা আসছে। My apologies. Okay, let's begin. So we were over here in placenta accreta. We were waiting for a device for my father. It just came. I apologize. Let's begin with placenta accreta. Okay, so one more time over here. If we have the decidua that is forming with an abnormality, will this allow the placenta to get attached to the uterine myometrium? Yes or no? Last answer, please. Okay. Okay, good. If that happens, isn't there a possibility that the placenta can get attached to the uterine myometrium very strongly? The answer is yes. So that's that. So now the next question is, why do we get decidual abnormalities? Why do we get decidual abnormalities? Isn't there a possibility that the mothers can have a prior cesarean section? Yes or no? Do you realize if a mother has a prior cesarean section, the endometriums, they get severely damaged and the formation of decidua can be hampered? Yes or no? The answer is yes. Or if there's any other uterine surgery, or let's say fibroid, endometritis, or advanced age, on all of these sections, prior C-section, myometrium, inflammation, in all of these cases, the endometrium, is it weak or not weak? Fast answers, please. The endometrium, not the myometrium. The endometrium, it's weak. If it's weak, will we have proper formation of the decidua? Yes or no? The answer is no. If there is no proper formation of the decidua, then can we expect that the placenta to get attached to the myometrium very, very strongly? Yes or no? The answer is yes. Okay. So next time, if you receive a question in your Usmle Step 1 exam where they tell you that there is a female who has had a live birth, but the female has had a history of CS or endometritis or uterine manipulation or let's say dilatation and curettage, can we expect these patients in your question stem can be patients of placenta accreta? Yes or no? Fast answers, please. Yes. If I tell you there is a patient who comes to you with severe abdominal pain, right, with a history of trauma or a history of advanced age, or if the patients, they have a history of smoking, hypertension, and cocaine use, there's severe abdominal pain, the abdomen is rigid, and there's a small amount of blood that's coming out paravaginally in the 3rd trimester. What is your diagnosis? Abruption placenta. Okay, good. Now, placenta accreta. How many types of accreta spectrum do we have? We have accreta, increta, and parcreta. Accreta means attachment to the myometrium. Increta means penetration into the myometrium. Parcreta means penetrate the myometrium and go all the way to the uterine serosa. This is basically divided on the extension of the placenta. If the placenta only attaches to the myometrium, right, through the decidua, because the decidua is defective, what is this called? This is called accreta. If they penetrate and attach to the myometrium, I mean, if they penetrate the myometrium, then we call this increta. If they attach, penetrate the myometrium and attach itself to the uterine serosa, we call this parcreta. Are we clear? Yes or no? So which one has the worst prognosis? Parcreta. Okay, as simple as that. So they invade the uterine wall. They can result in placental detachment, and presentation-wise, they're often detected on ultrasound prior to delivery. No separation of placenta after delivery. If there is no separation of placenta after delivery, do we get postpartum hemorrhage? The answer is yes. Another thing is, let me ask you a very, very quick question. If you have a patient, let's say you're a gynecologist, you have a patient who calls you, because nowadays patients, even in the US, do they go for live births in the house? Yes or no? Home birth or a birth that takes place in the house or whatever, where they take birth in a water pond or something like that. Like I'm not really sure what people are into nowadays, but you know, like how nowadays, like it's a big thing in the social media that they want to promote home pregnancies, right? What they do is that they buy those portable swimming pools, fill it up with water, and then they have a home pregnancy. Okay, you will get a lot of questions in your USMLE step 2 CK, where a patient, you have to counsel the patient that they should have a pregnancy in the hospital and not at the house. But some patients, they are very adamant on having these sort of pregnancy in the home. Now, let's say you have a patient's husband. The patient's husband calls you and tells you that my wife just had a home pregnancy, but the baby is healthy, but the placenta is not coming out. Okay, are you going to advise the mother to try to get the placenta out, or are you going to advise them to come to the hospital immediately? The answer is come. Okay, if you advise, for example, if the placenta stays attached to the myometrium, is there a less chance of bleeding? Yes or no? The answer is yes. So any female who has a home pregnancy, and if they have the delivery of the fetus, but not the delivery of the placenta, should they try to take the placenta out by themselves? The answer is absolutely not. Okay, absolutely not. It's better to have placental retention than to have postpartum hemorrhage. Okay, it's better to have placental retention than to have postpartum hemorrhage. Okay, so no separation of the placenta. But there's another thing. If the placenta stays retained for a long period of time, can we get endometritis and infections? Yes or no? The answer is yes. Can we also get DIC? Yes or no? The answer is yes. Okay. So better to have pregnancy in the house or in the hospital? The answer is always hospital. Okay? I'm not really sure how someone is brave enough to have a pregnancy in the house. I would never be able to convince my wife to have her pregnancy in the house, even if I'm a physician, everyone else in the house is a physician. Even then, a hospital pregnancy is the most safest mode of delivery. Okay. Next one is placenta previa. What do we mean by placenta previa? You know, the word previa comes from the Latin word that is preview, meaning that, for example, before we see a movie, do we see a trailer? Yes or no? Do we see a trailer? The answer is yes. Do we call that a preview? Yes, a preview, meaning pre-view, right? Previous view, meaning that viewing before the actual thing. Is placenta something that should be viewed before the delivery? Yes or no? The answer is no. So do you realize how smart this word is, placenta previa, meaning that you have a preview of the placenta even before you should be seeing this. So this is a placental trailer. Okay. Why do we see placental trailers or placental previews? The answer is because in certain patients who has had a risk factor of cesarean sections in the past, Patients who has had cesarean sections in the past, do they have abnormal formations of the decidua? Yes or no? The answer is yes. Okay. Now, if you think about placenta, isn't there a possibility that placenta will always try to attach to the myometrium where the decidual level is a little bit weak or absent? The answer is yes, right? So in these patients, the cesarean section usually happens at the lower uterine segment, as you can see in the lower uterine segment. And this is the area of the uterus in the lower uterine segment that the decidua formation is a little bit hampered, which allows the placenta to get attached to the myometrium in the lower uterine segment, resulting in the placenta being previewed before delivery of the fetus. So patients of placenta previa, should they have a history of prior cesarean sections? Yes or no? The answer is yes. And the next question is, females who has had previous cesarean sections, do we more or less allow them to have a normal vaginal delivery in their subsequent pregnancies? Yes or no? The answer is no. Patients who has had cesarean sections, there's a high possibility they need to have another cesarean section. Have I made myself clear? Yes or no? Patients who has had cesarean section, there's a higher possibility they need to have another cesarean section because of the fact that there could be placenta previa, there could be multiple other complications, which we do not want to induce with a normal delivery. So if you have a patient who comes to you with minor bleeding and during pervaginal examination, you can view the placenta like this. What is the name of this disease? The name of this disease is placenta previa. If the placenta is completely visible, if the placenta is completely attached to the uterine, to the lower uterine segment, we call this complete placenta previa. If it's partially attached, we call this partial placenta previa. Now, the question of the hour is: are you willing to allow normal vaginal delivery in these patients? Yes or no? No, right? Because why? It's common sense, right? If the placenta is attached over here, in normal vaginal delivery, the fetus will come through over here. So will they come out with the placenta and the placenta will come off and there will be excessive bleeding and the fetal will be distressed? The answer is yes. Okay. So always go for cesarean section. Okay. It's associated with painless third trimester bleeding. So if I say painful third trimester bleeding, what is the diagnosis? Abruptio placenta. If I say painless third trimester bleeding, what is the diagnosis? Diagnosis is placenta previa. Okay. Okay, good. Next one, pregnancy complications, is vasa previa. Is this also a trailer? Yes or no? A previa? Yes. Now, instead of seeing the placenta, can we see the blood vessels? Yes or no? The answer is yes. So when we do pervaginal examination, if we see blood vessels, right? If we see blood vessels, especially the umbilical blood vessels, do we allow the fetus to come out through the normal vaginal delivery? The answer is no. Why? Because isn't there a possibility that when they come out, they can rupture the umbilical, the umbilical cord and the umbilical blood vessel? The answer is yes. And also, can they also have umbilical cord suspensions around their neck? Yes or no? The answer is yes. Okay, so that's that. So what is vasa previa? Vasa previa is a preview or a trailer of the umbilical blood vessels and the umbilical cord even before we should be seeing this. So this may result in vessel rupture, exsanguination, fetal death. This presents with a triad of membrane rupture, fetal bradycardia, and bleeding. So painless bleeding and fetal bradycardia. Fetal bradycardia is your sign that the fetus is in severe distress, In these cases, do we go for normal delivery or do we go for emergency cesarean sections? We go for CS. Okay, as simple as that. It's frequently associated with umbilical cord insuction, and fetal vessels travel to the placenta unprotected by the Wharton jelly. So what happens is that the cord inserts in the chorionic membrane rather than the placenta, and this allows the vessels to travel to the placenta unprotected, meaning that in the umbilicus, do we have the blood vessels suspended in the Wharton's jelly. Do you guys remember that picture in the umbilicus where it looked like a face, the two umbilical blood vessels, and over here like this? Yes or no? With the allantois and the urachus. Yes. You guys remember that face, like that face? Okay, which one am I talking about? I'm talking about this one. Wait, 1 second, 1 second. Not the anatomy. Okay. Give me 1 second, please. This one. Okay. Do we have the umbilical arteries and the umbilical veins suspended in the Wharton's jelly? Yes or no? The answer is yes. If the umbilical arteries and the veins were not suspended in the Wharton's jelly, could they be roaming around freely in the placenta? Yes or no? The answer is yes. So that's exactly what happens, right? So that's exactly what happens in vasa previa. In vasa previa, we have the umbilical arteries and the umbilical vein that are freely roaming around without the absence with the absence of the Wharton's jelly. And this allows the blood vessels to be present all over the placenta. So whenever we view the patients paravaginally during pregnancy, we can visualize the blood vessels. As simple as that. So this is known as vasa previa. Now, in a patient of vasa previa, how do we manage them? I've already told you this. We manage them by doing a cesarean section, and an emergency cesarean section. Okay, so that's it. The next thing that I want to talk to you guys about is I want to talk about postpartum hemorrhage while this loads up. What is postpartum hemorrhage? Postpartum hemorrhage is basically a condition where we have severe postpartum bleeding. And can anyone tell me the #1 cause of postpartum hemorrhage, the most common cause of postpartum hemorrhage? First answer, please. The most common cause of postpartum hemorrhage is uterine atonicity, meaning absence of uterine tone, right? The uterus becomes really lax, or they become really, they do not contract, right? When they do not contract, they become atonic. And when they become atonic, they bleed more. Because if there's an atonic uterus, do we have vasodilatations or vasoconstrictions? First answer, please. We have vasodilatations or vasoconstrictions? We have vasodilatations. Very good. Atonic uterus. In atonic uterus, vasodilatations or vasoconstrictions? Fast answer, please. Vasodilatations, right? This is a very normal, common concept. If there is an organ that is dilated, if the organ is dilated and relaxed, the blood vessels will also be dilated and relaxed. So if the uterus is atonic, then we have vasodilatation that actually promotes more bleeding. There could also be trauma. That could be another cause. There could be thrombin or coagulopathy, or there could be retained products of conception. That is, retention of placenta can also cause postpartum hemorrhage. So that's that. Now, how do we treat postpartum hemorrhage? Treatment of postpartum hemorrhage is not so simple. First and foremost, let me just tell you, if you have a patient of postpartum hemorrhage who comes to the emergency department, #1, are you willing to open 2 large IV bore needles on each arm? Yes or no? First answer, please. Yes or no? The answer is yes. Then are you going to infuse saline to maintain the hemodynamic status of the patient? The answer is yes. After that, will you ask the patient's family to go and arrange for blood? Yes or no? The answer is yes. Okay, because blood for blood. Okay, and if while they go and arrange for blood, are you going to start a massive transfusion protocol? That is blood, platelets, and plasma? Yes or no? The answer is 1:1:1. Blood, platelet, plasma. Fresh frozen plasma, blood, and platelet. So 1:1:1. This is called massive transfusion protocol. After that, are you going to give the patient oxytocin? Yes or no? To cause contractions of the uterus? The answer is yes. If oxytocin does not work, can we go for surgical intervention? Yes or no? By ligating the uterine blood vessels? The answer is yes. Very quickly, if we want to ligate the uterine blood vessels, which ligament do we ligate? Cardinal ligament, round ligament, suspensory ligament, or cardinal ligament. Very good. Okay, we ligate the cardinal ligament. Even after ligating the cardinal ligament and everything else, if the uterus does not stop bleeding, can we, in the last stage, can we perform a hysterectomy? Yes or no? The answer is Yes. Okay. Okay, good. But it never goes as far as performing a hysterectomy. Usually by the time we give IV fluid, blood, and oxytocin, the bleeding usually stops. Okay, that's that. Next one is ectopic pregnancy. What is ectopic pregnancy? Ectopic pregnancy is basically a condition where we have implantation of the ovum in a site other than the uterus. The ovum gets implanted in the posterior wall of the uterus, and most often in the ampulla of the fallopian tube. For example, let's say that these are the ovaries, right? These are the fimbrias. This is the ampulla, right? This is the fallopian tube. I'm sorry, instead of drawing a uterus, I think I draw that one. Just give me 1 second. Let me just, okay, 1 second. Okay, 1 second. Okay. Okay, good. Now, do we have fertilization in the ampulla? Yes or no? The answer is yes. After fertilization in the fallopian tube, do we have the simple ciliated columnar epithelium moving back and forth, moving the zygote this way for implantation in the uterus? Yes or no? The answer is yes. If we have a patient who has primary ciliary dyskinesia or cystic fibrosis or anything that is wrong with the cilias of the fallopian tube, will the zygote move towards the uterus? Yes or no? The answer is no. In that case, will they get deposited? I mean, the zygote, can they get implanted in the ampulla of the fallopian tube where they were fertilized? The answer is yes. And if they start to grow at one point, do you think that the fallopian tube can host a full pregnancy? The answer is absolutely not. So at one point when the fetus, they start to grow, can the fallopian tube rupture and have excessive internal bleeding in the mothers? Yes or no? The answer is yes. Okay. Now, risk factors are tubal pathologies. Patients can have primary ciliary dyskinesia. Patients can have cystic fibrosis. Patients can have previous history of inflammation. If there's a patient who has had repeated salpingitis or endometritis, do they have more chances of fibrosis and synechiae formations? Yes or no? The answer is yes, right? They can have more chances of fibrosis and synechiae. And if there's another history of surgery, can we also expect there to be some sort of occlusion for the movement of the zygote towards the uterus? Yes or no? The answer is yes. In those cases, we can expect patients to suffer from ectopic pregnancy, as simple as that. So previous ectopic pregnancy is a very high risk. Intrauterine death is a very high risk. IVF, in vitro fertilization, is a very high risk. PID is a very high risk for fibrosis, and so is primary ciliary dyskinesia and cystic fibrosis. Okay, so that's it. This presents with first trimester bleeding. So patients, they will have amenorrhea with severe pain and bleeding all of a sudden. And when they come, whenever a patient of reproductive age comes to the ER with severe abdominal pain, do we do a beta HCG? Yes or no? The answer is yes. Right? If the beta HCG is very high and the females, they have severe abdominal pain and bleeding, can we expect these patients to be suffering from ectopic pregnancy? Yes or no? The answer is yes. We can do an ultrasonogram. In an ultrasonogram, we will find that there is the presence of the fetus in the fallopian tube. And these patients, do they need to have emergent surgery or not? Yes or no? The answer is yes. Okay. But if it's in a very early stage, in that early stage, can we give methotrexate? Yes or no, to stop the uterine growth of the fetus? The answer is yes. How will methotrexate help? Will methotrexate kill the developing fetus? Yes or no? Will kill the zygote? The answer is yes. How? By depleting the zygote of folic acid, and the zygote will die. Okay, and right, exactly. When they are depleted of folic acid, they cannot have DNA synthesis, and then they will die. Are we clear, guys? Yes or no? Okay, good. Okay. Next one is heredity formal. Before we begin heredity formal, can we take a quick 5-minute break, please? Yes or no? Okay, before we take the break, quick questions and quick answers. If you have a patient who comes to you in the third trimester with excessive vaginal bleeding and abdominal pain with a history of smoking, cocaine use, and what is your diagnosis? Abruption placenta. Very good. If there's a female who comes to you with a history of previous cesarean section, endometritis, or DNC, now the patient has a full live pregnancy, but the placenta is not coming out. The placenta is attached to the uterine serosa. What is your diagnosis? Uterine serosa. Placenta? Parkrata. Very good. Okay. If there is a patient and during pervaginal examination in the third trimester, you have a little bit of bleeding and you see the placenta visible through the lower uterine segment, what is your diagnosis? Placenta previa. If you see the blood vessels, what is your diagnosis? Vasa previa. If there's severe postpartum bleeding, what is the number one cause? First answer, please. Severe postpartum bleeding, atonicity. If there is a patient who has had history of previous cesarean section, ectopic pregnancy, PID, smoking, and primary ciliary dyskinesia and cystic fibrosis, now comes to you with excessive vaginal bleeding and severe pain and positive beta HCG. What is your diagnosis? This is ectopic pregnancy. Very good. If you have another patient who comes to you with hypogonadism and the patient cannot smell anything, what is your diagnosis? First answers, please. Coleman syndrome. If there's a patient who has ambiguous genitalia, but in the later stages of life, the patient has virilization and normalization of the phenotype, what is your diagnosis? This is 5-alpha reductase. If you have another patient who has cryptorchidism, testicular cancer, the patient has phenotypically it's a female, and also the external genitalia is that of a female. What is your diagnosis? Androgen insensitivity. If there's a mother who gets severely virilized during pregnancy, what enzyme is absent in the placenta? Last answer, please. This is placental aromatase deficiency. If there is a male who comes to you who is unable to conceive a child with infertility, wide hips, testicular atrophy, and gonadism, what is your diagnosis for this patient? Klinefelter syndrome. If there's another female who comes to you with shielding of the chest, widening of the shoulder, webbing of the neck, streak ovaries, this is Turner syndrome. Okay, so can I assume that you guys have understood the concepts which I have talked about in the last 1 hour? Yes or no? Okay, so congratulations. Thank you so much. You guys are very, very good students, and I'm very proud of you guys. Thank you so much. Keep up the good work. And over here, okay, let's take a quick 5-minute break, and then after that, let's begin. Okay. Thank you so much. Okay, is everyone back from the break? Can everyone hear my voice? Yes or no? Can everyone hear my voice? Yes or no? Yes. Yes. Okay, Dr. Hagar is back with 2 yeses. Is anyone else back with 2 yes? Is anyone else there? Can anyone hear my voice? I'm back with 1 yes. Okay, Dr. Alam is here. Who else is here? Who else is here? Who else is back from their break? I said a 5-minute break, not a 15-minute break. Okay. No, very quickly, I just want to discuss something with you guys over here. Whenever there is implantation, is there always a formation of a fetus, or can we have formation of an abnormal structure that is not a fetus? Flash on this, please. Guys, can you guys hear my voice? Again, okay. Okay, so what I'm trying to explain to you is whenever we have an ovum and a sperm, when they meet together, there is supposed to be fertilization and formation of a fetus. Yes or no? The answer is yes, right? But in some cases, instead of forming into a fetus, when the ovum and the sperms, when they fertilize and they implant, instead of a fetus, can we have a structure that is not a fetus, but a mole? Yes or no? The answer is yes. So it will be very surprising for you guys to understand because 3 years ago, even me as a physician or a medical student who has just passed his bachelor's of medicine and surgery, even I had no idea what hydatiform mole was. In my mind, I knew that this was a disease, but I didn't know that this disease is as simple as an ovum and a sperm. They meet together, and instead of forming into a fetus, they form a mole. As simple as that. So, what is hydatiform mole? Hydatiform mole is basically a condition where when there is fertilization, there's formation of an abnormal structure. This structure, instead of forming into a human, they form a mole. And this mole is a cystic swelling of chorionic villi and proliferation of the chorionic epithelium. So, like how when we have the zygote, when it is formed, it starts to implant. And when it implants, there's formation of placentas and the chorionic villi and syncytial trophoblast and cytotrophoblast? Yes or no? The answer is yes, right? In these patients, whenever we have implantations, what happens is that instead of the zygote, first of all, you have a mole, and when they implant, there is swelling of the chorionic villi. And this swelling of the chorionic villi also results in proliferation of the trophoblastic layer, right? The trophoblastic layer has cytotrophoblastic layer and syncytial trophoblastic layer. So both of these things, they proliferate. Now the question is, cytotrophoblast is responsible for cellular synthesis? Yes or no? Fast answers, please. Very good. Syncytial trophoblast is responsible for HCG secretion? Yes or no? The answer is yes. So if cytotrophoblast is responsible for cellular synthesis, if there's an abnormal proliferation, will there be excessive cellular synthesis? Yes or no? The answer is yes. Will there be excessive production of HCG from syncytial trophoblast? The answer is yes. So can we expect these patients to suffer from either a benign mole or a choriocarcinoma if there is excessive proliferation of cytotrophoblast? The answer is yes. And the HCG level in these patients, will they be really high or really low? The answer is they will be really, really high. So that's that. So what is hydatiform mole? Patients, instead of having a live pregnancy, they have a mole. So they come with vaginal bleeding, severe hyperemesis gravidarum. Hydatidiform mole is a very high yield diagnosis of hyperemesis. So patients, they will have severe vaginal bleeding, and they will have emesis, and uterus will be enlarged. So there will be uterine enlargement more than the expected age of gestation, as simple as that. So when we do a visualization on the abdomen or by an ultrasonogram, can we see cystic dilatations of in the uterus? Yes or no? The answer is yes. Not snowstorm. Not snowstorm. Snowstorm is in the lungs. In the uterus, in ultrasonogram, there will only be cystic dilatations. As simple as that. So when this happens, first and foremost, treatment is very simple. We need to dilate and curate and remove all the hydatidiform mole. And then we can also give methotrexate that will decrease the growth of the developing mole. And we can monitor the HCG to our treatment. Now, it's not as simple as that because moles are of two types. There could be complete mole or there could be a partial mole. A complete mole is one which is the most common type, which has a normal genotype. A partial mole is one where we have 2 sperms and 1 egg. So there is 3 types. So you have 23 times 3. You have 69, right? 3 3s are 9, 3 2s are 6. So 69 XXX, XXY, or XYY, as simple as that. The components are that why do we have a complete mole? Why do we have a partial mole? We have a complete mole. We have a complete mole because the egg is enucleated, meaning that the ovum does not have a nucleus, but the sperm is a single sperm, which can duplicate. So that's why, since the female's egg does not have a nucleus, the female's genotype number is 0, the sperm genotype number is 46. Over here, since the egg has a nucleus, you have 23, and the 2 sperms, you have 46. So 23 plus 46 is 69, as simple as that. So this is the only difference. Histological wise, you will see hydropic villi, and over here you will not see hydropic villi, meaning that the villi will be severely swollen in a complete mole. In a partial mole, they will not be swollen. Another one is that in a partial mole, the trophoblast does not proliferate as much, but in a complete mole, there's diffuse trophoblastic proliferation. If there's diffuse trophoblastic proliferation in complete mole, which one has a more chance of forming into a choriocarcinoma? Last answers, please. Complete mole or partial mole? The answer is complete mole. Very good. Okay. Next one. If there is severe trophoblastic proliferation in complete mole compared to partial mole, HCG will be higher in which one? Complete mole or partial mole? The answer is HCG will be severely high in a complete mole. Okay. Risk of invasion and turning into carcinomas are more high in complete mole or partial mole. That is, they're more high in complete mole and then partial mole. Okay. And forming choriocarcinomas, right? Choriocarcinomas are also more high yield. So patients can have honeycomb uterus or snowstorm appearance of the uterus or snowstorm appearance of the lungs in case of a choriocarcinoma. So that's it. And which one will have fetal parts, partial mole or complete mole? The answer is partial mole will have fetal parts. Why? Because of minimal trophoblastic proliferation, they will have some amount of fetal parts. As simple as that. Staining for P57 protein, not important. Okay, not important. Next one is choriocarcinoma. Choriocarcinoma is a rare but can develop during or after pregnancy. This is the malignancy of the trophoblastic tissue, especially cytotrophoblasts and cytotrophoblasts. Over here, what happens is that there is increased risk of formations of choriocarcinomas and metastasizing into the lungs, which can result in a snowstorm appearance of the lungs. Along with this, patients will have increased HCG. So if a patient comes to you with weight loss, hemoptysis, fever, night sweat, and increased HCG, especially in females with a recent pregnancy, what is your diagnosis? The diagnosis is, fast chances, please. The diagnosis is choriocarcinoma. Yes or no? Choriocarcinoma. Okay. As that. As simple as that. Okay. So quick question, quick answers. Quick questions and quick answers. Okay. If there's a fetus, right? If there's fertilization and there's no formation of fetus, what do we call this structure? We call this structure as a mole. Okay, how many types of mole are there? Complete and partial mole. Which one has more trophoblastic proliferation? Complete mole or partial mole? Fast answers, please. Complete mole. Which one has one enucleated egg and 2 sperms? Complete mole or partial mole? Complete mole. There you go. Which one has 1 egg and 2 sperms that are viable? Fast answers, please. Partial mole. There you go. Which one has 69 chromosomes? XXX, XXY, or XYY? Partial mole. There you go. This one has 46. Which one has fetal parts? Complete mole or partial mole? Partial mole. There you go. Which one has more chances of developing into an invasive mole and choriocarcinoma? Complete mole or partial mole? Complete mole. There you go. Next one is which one will have hydrophic villi and diffuse trophoblastic proliferation? Complete mole or partial mole? Complete mole. As simple as that. Okay. If we have a patient with hemoptysis, weight loss, cannonball appearance in the lungs, HCG is high with recent pregnancy, what is the diagnosis? Choriocarcinoma. Okay, that's good. Okay. So for today, can I keep the class up to here? Yes or no? I have to address my father very quickly. I apologize, but I need to end the class over here right now. Tomorrow I'll begin the class once again. The class for tomorrow will begin at 10 a.m. by the way. Okay, it will begin at 10 a.m. Okay. So even though we are ending the class a little bit early, did we complete a lot of pages? Yes or no? How many pages did we complete? 1, 2, 3, 4, 5, 6, 7. Okay. Okay. All right. Now, can we expect you guys to read the text that we have studied today in the house, and tomorrow we can do it? We can do some questions in the class. Yes or no? Yes. Okay. Good. Thank you so much. Hope you guys have a great day. I'll see you guys tomorrow at 10 a.m. We also have an evening class if you guys want to join. I will be sharing the evening class lecture link in the Dr. Haidari Step 1 Facebook page. If you guys want to join and revise on your CVS, you're more than welcome to do so. If you have friends who also wants to come and join, please let them know. So thank you so much. I'll either see you guys today at 5:30 or tomorrow morning at 10 a.m. Thank you so much, and God bless you all. Bye-bye.